I'm going to kickstart the questions, Rabbi, and with the genetic side of things.
Yes, please.
So here we are in 2024, and you make a diagnosis on scan of tetralogy of fallow, let's say, or you make a diagnosis of, well, let's start with, say, conotruncal abnormality. The rest of the baby structurally looks normal. As you say, Rabbi, how do you know when it's isolated? But let's say the scan's done by you, Rabbi, so it's isolated.
Not even me.
So you have an isolated abnormality, and you are at 20 weeks of gestation. I'll start with 20 weeks, then I'll go back to 13. You're at 20 weeks of gestation. I want you to give me an overview of where we stand with regard to your thoughts on genetic associations and the process by which you go about amniocentesis and what tests you run in terms of starting off with fish, 5-probe or 6-probe fish from banded karyotype to chromosomal microarray to exome sequencing, where we are today and where you think it's going in the future.
Well, this is quite easy question, actually, but the answer...
Easy for you.
No, but I mean, it's a straightforward question because it's could be every day occurring, nothing special at all. But let's say what we should also emphasize all the time is genetic examination like exome is evolving and the price is going down. We used to spend earlier for Sanger sequencing some 4 weeks. Today, they are finishing the exome examination within 2 weeks and sometimes easier than doing the karyotype. So the problem in all our discussions is some tell me in our society it's not covered by the insurance company. In this society it's covered and so on. Because if this is the basic of discussion, it's not scientifically. From scientific point of view, you should today do exome. Period.
Yeah.
Because in 5 years from now, people say, okay, we are doing exome. I remember there was time said, do you really perform macroarray on every fetus today? So you ask, why are you not doing this anymore? So this is why the answer should be independent on insurance coverages. What would be the best approach? The best approach for our geneticists is we do for next day the fish plus 22q11, and they start after that running the exome, the trio exome. So this, because then if you have an Alagille syndrome, you may discover this in 10 days after the examination. If you do microarray, you wait 2 weeks, and it is normal. You run after that additional 2 weeks. You have 4 weeks waiting until the result.
But Rabbi, that's, I mean, when you're running 2 tests in parallel, I mean, there's the whole additional expense of running 2 tests in parallel, no?
But you know, cardiac surgery is not cheap, neither.
Okay. Yeah, because
one
I mean,
day,
the debate
one day on the intensive care, 2 days intensive care unit is already, let's say, exome plus extra. So.
Yeah.
You know, if you tell the parents, and either you can afford to pay this amount of money, or you have a lifelong baby with, let's say, problems, they may discuss with you. And some, let's say, in some situations, they may come and say, you know, I'm not really daring to have a child with tetralogy because I may consider termination pregnancy. I said, no, please, give it a chance. If it's isolated, the chances are excellent. So, and then we go for isolated. And how can you exclude isolation? We tell them this is the maximum we'll do. I'm sure, I bet with you, in 3 years we'll be sitting here and you'll ask me, Rabbi, are you still doing exome? Why are you doing genome sequencing?
Yes.
Because it's quicker, cheaper, you are finishing within 5 days. And why are you still doing exome? I will tell you, because the insurance company is not paying for exome. This is because, this is quite developing.
And I think, I mean, I'm looking forward to Jelani and Bev's take on this in terms of a postnatal point of view, so we'll probably come back to that in a second. Fanula, the Irish context in terms of diagnosis of major congenital heart defects and what's the state of play in terms of genetic investigations process?
Well, I mean, we have good... Can we go to the lectern? Yeah, I think we have good antenatal detection. I think it's around 50%, which is similar to other international centres in terms of antenatal detection of congenital defects. We do have a paucity of geneticists in this country, so we've a very small number, but we do have a perinatal geneticist based in National Maternity Hospital. So we would do karyotype microarray, and then, depending on the result and other scan findings, then to go on to exome, but it would be something we would do as a second stage. And I suppose one of the issues that we find, of course, is if we do find genetic results that we're not sure what they mean, there, extensive counselling is needed, and the implications for parents and family and so on. So I think the genetic testing should be done in the setting of, a robust and supported genetic service.
I mean, I think that's a very key point in a sense, and it's a very relevant one in Australia. Firstly, it's the late diagnosis, because by the time we don't have the luxury, in a sense, what Rabi has with exome sequencing as a first-line option. We do the amnia, we do a FISH, we do a chromosomal microarray. The diagnosis is made at 21 weeks. By 23 weeks, you have your result, and then you run exome sequencing. The patient's 26 weeks of gestation before you get a result of potential monogenic disorder. Well, you need to have an infrastructure, number one, to support the counselling that goes around that. The second point is, in a sense, of exome sequencing in terms of these variants of uncertain significance is in a sense opening a can of worms, and in a sense to be able to provide this, not just by getting a right diagnosis, in a sense it's about having an infrastructure to interpret many of these monogenic disorders that are picked up on, and for us this is becoming a real challenge. But I think the way the world is shifting, and maybe Dario, if you agree with me on this, in a sense, it points to the emphasis of first trimester diagnosis, because the way currently, and I think Australia is similar to many countries that are doing it, they're doing chromosomal microexome sequencing process. It's a third trimester diagnosis that you're coming up as a monogenic disorder. I think it points to the emphasis of first trimester diagnosis. Do you agree?
Yeah.
And in a sense of, in a first trimester diagnosis screening setting, I know we always come back to a debate of vaginal versus abdominal, but if you just want to comment maybe, Dario, on the importance of that and detection rates in terms of first trimester.
Well, of course it does, Simon. You're one of the, together with Rabi and everybody, key believers in the fact that you can screen for congenital heart disease in the first trimester. We publish also in that field, and I think nowadays, with unfortunately large exceptions of increased BMI, but you can carry out wonderful screening with the current top transducer, high-frequency transducer in the first trimester. So that's very relevant, because if you get a cardiac defects very early in pregnancy, then you have the option to carry out all genetics tests much earlier than you would do for later diagnosis. So that's quite important.
Yeah, thanks, Dario. Rabi,
I've got often a question: what do you do if you offer Invasia and the patient says she doesn't want to? Say, okay, so if you see nothing else, so good luck. You have only to write down, document that you told her that between 10-20% of the cases there may be monogenic disease, that she cannot come later on. That if I knew this, so. But if they don't want to do it, so why not? The opposite group is, they say, we ask them, why you don't want to know? We said, I will not change my decision. So if in that cases you are